by Dr. Anne May from the University Medical Center at Utrecht in the Netherlands. Effects of a structured and individualized exercise program on fatigue and health-related quality of life in patients with metastatic breast cancer, the multinational randomized controlled preferable effect study. Dr. May?
Okay, thank you. So thank you for selecting this abstract, and we will now move to Europe. So my velocity is somewhat slower than the former speaker's velocity, but I'm very happy to present today the results of our preferable effect study to you. And let me see. In this study, we investigated the effects of exercise in the metastatic breast cancer setting. And last year, ESCO published a guideline guiding clinicians on how to recommend exercise to patients with cancer. And in this guideline, before we published the guideline, we did a thorough literature review, and we found that there was convincing, strong evidence that exercise during adjuvant treatment for cancer leads to improvements in cardiovascular fitness, strength, fatigue, and other patient-reported outcomes. So the recommendation was that oncology providers should recommend exercise to patients during treatment with curative intent. There were also gaps we found, and one of the gaps was that there were no studies in the metastatic setting. So we could not publish a guideline on how patients should exercise during their metastatic disease. And the recommendation for future research was to do studies and include those patients with metastatic disease. And the aim of preferable effect perfectly fits that recommendation, because we aimed to study the effects of supervised, individualized exercise in patients with metastatic disease on their fatigue and quality of life. For this study, we included patients in 8 centers in 5 European countries and in Australia. Here you can see the design of our study. We included patients, adult patients, diagnosed with stage 4 breast cancer and with an estimated life expectancy of 6 months or longer. Then, after informed consent, we performed baseline measurements, which entailed filling in questionnaires to assess quality of life and fatigue. We drew blood samples, and patients underwent fitness testing. And all these measurements were repeated at 3, 6, and 9 months. After that, patients were randomized to either the intervention group or the control group. And the control group received care as usual, and in addition they received a physical activity advice and an activity tracker. The supervised intervention group received an exercise program for 9 months that was supervised by either a physiotherapist or a physical exercise professional. And they visited their physiotherapist, for example, twice per week for 1-hour sessions. And after 6 months, one of these supervised sessions was replaced by an unsupervised session. So what did they do? Let me see. Yeah. Each session they performed aerobic resistance and balance training. That means that they did exercises on, for example, a cycle ergometer, and this was done with moderate to high intensity interval training. So the intensity of our exercise was quite high. Furthermore, they exercised all their muscles of their body, so all lower and upper muscles to get strength, and they did balance training. Here you can see our outcomes. We had 2 primary outcomes. So we assessed effects on physical fatigue and quality of life with questionnaires of the EORTC, and we had several secondary outcomes, and today I only will present the results for physical fitness. And our trial was defined to be successful if either or both primary endpoints were statistically significantly different between the 2 groups at 6 months. We included 357 patients in our trial and randomized half of them to the intervention group and the other half to the control group. The baseline characteristics of our study sample were well balanced between this group, and patients were about 55 years of age. We had 1 man in each group, and most of the patients had recurrent disease, received first or second line treatment, had bone metastases, and underwent endocrine treatment at start of our intervention. So let's move to our primary results. And these were, so our primary endpoints were fatigue and quality of life. For quality of life, we found that the exercise intervention had Let me see whether I can use the pointer. No, I can just talk. So as you can see, quality of life is higher in the exercise intervention group as compared to the control group, and this was statistically significant at 6 months. And also for fatigue, we found, and now you need to look at the lower line, that fatigue was lower, so it decreased, and it kept lower in the intervention group as compared to the control group. So from these results, we can conclude that also patients during metastatic treatment do benefit from exercise in terms of their side effects and quality of life. We also looked into some distressing complaints patients have during their treatments, and that was pain and dyspnea. We found that about 60% of our sample had pain or dyspnea at baseline that was above a clinical relevant threshold. And we know that these complaints can also withhold patients to start exercise because they worry that these symptoms will increase. But what we show here is that patients in the intervention group had lower levels of pain during the intervention, as well as lower levels of dyspnea at 6 months. So this is really reassuring that symptoms do not increase by exercise, but they decrease. And we also had other results, and we found, for example, that adherence to this intervention was good. Patients were able to attend a median of 77% of all sessions, and reasons for non-attendance were medical or vacations during a 9-month period. And the dropout of our, at the primary endpoint was 18%, and beforehand we had estimated a 20% dropout, and half of the dropout was due to death. We also found positive effects of exercise on, amongst other, physical fitness, physical functioning, and social functioning. And the latter means that patients reported that they could better function in their social life, so being together with their family and friends, but also in, if still applicable, in their working life. And what we did not find were effects on emotional functioning of emotional fatigue. So that means if these are predominant complaints of patients, there's need for an additional intervention. So I would like to finalize this presentation with some patient experiences. These were 2 participants in our trials, and the woman to the left said, "For me it was a good opportunity to get out of the house and stop thinking. Thanks to the coaches for not giving up when I wanted to give up." And the other woman on the right said, "Wonderful. Even though I'm very ill with chemotherapy, I come, I exercise, and I even leave better." And I think this latter really shows what we often hear, that even if you are very fatigued, exercise still helps you to feel better afterwards. So to conclude, we found that a supervised resistance and aerobic exercise intervention resulted in beneficial effects on fatigue, health-related quality of life, and other clinically relevant outcomes of patients with metastatic breast cancer. So we recommend supervised exercise as part of supportive care regimens during palliative treatment. And actually, I think that exercise should be part of the cancer treatment of the patients. So I would like to thank all our participants, the treating physicians who recruited, the exercise specialists who supervised the trainers, and all my co-workers, because this was really a study where we worked together and everyone contributed to it. And last, I would like to thank the funders, which was the European Union and the Australian government. Thank you.